Hello, and welcome to our presentation today. This presentation is being given to the Indiana Rural Health Association. My name is Susie Murray. I am the Diabetes Prevention Coordinator for the Indiana State Department of Health, and today's topic is prediabetes, defining, screening, diagnosing, and further resources. Without further ado, let me introduce to you the presenters for today. We have on the phone with us Dr. Tamara Hannon. She is an associate professor at Indiana University School of Medicine in the Department of Pediatrics, section of Pediatric Endocrinology and Diabetology. She is the clinical director for the Pediatric Diabetes Program and the Youth Diabetes Prevention Clinic at Riley Hospital for Children. She is the current president for the Community Leadership Board with the Indiana chapter of the American Diabetes Association. Thank you for joining us, Dr. Hannon. And then, after that, we will have Ms. Julie Pike. She is a dietitian. She works with Dr. Hannon in the Youth Diabetes Prevention Clinic at IU Health Riley Hospital for Children. Without further ado, Dr. Hannon, would you like to take it?
Great. So we'll go ahead and get started with the definition of prediabetes. Prediabetes is a condition that is basically defined as having a blood sugar or blood glucose or A1C levels higher than normal, so above the normal range for these values, but not high enough to meet the cut points for diabetes. The cut points for the diagnosis of diabetes were established based on their relationship to their association with complications of diabetes, such as retinopathy. So we know that people who have been diagnosed with diabetes, meeting those glycemic cut points, are at high risk for development of complications. So prediabetes is in the middle. And I've started to think of diabetes as more of a spectrum rather than an all-out yes or no condition. And prediabetes is in the middle of that spectrum. The reason why it's important to recognize prediabetes and to diagnose prediabetes is because those people afflicted with prediabetes have an increased risk for the development of type 2 diabetes and also heart disease and stroke. So this is a population that is going to experience further morbidity, and type 2 diabetes can potentially be prevented. People with prediabetes who lose weight and increase their physical activity levels can prevent or delay the onset of type 2 diabetes, which is very important when we look at health outcomes. In 2005 to 2008, surveys showed that 35% of U.S. adults aged 20 years or older had prediabetes. So more than a third of adult Americans have prediabetes. 50% of Americans aged 65 years and older have prediabetes. So we're talking, when we talk about older populations, the majority of us having the condition prediabetes. Applying this percentage to the entire U.S. population converts to nearly 79 million adults with prediabetes, which if you try to wrap your brain around this, whenever I try to wrap my brain around this, you know that the majority of these people are not getting treated and are probably not even diagnosed. The prevalence of U.S. adults aged 20 years or older with prediabetes is similar for the major race ethnic groups. So non-Hispanic whites, 35%, non-Hispanic blacks, 35%, and Mexican Americans, 36%. What does change is sort of the progression to diabetes. People of minority race or ethnicity have higher rates of progression to type 2 diabetes at younger age groups. So at the bottom of the slide, you have the percent of Hoosiers, or people living in Indiana, ever told they had prediabetes, and this is just 6.2%. So there is a big gap between 35%, which we know is more like the actual number of adults with prediabetes, and 6.2%, which is the people who actually think that they actually have prediabetes. So this is just to show that there's a huge number of people living in our state who are living with prediabetes, who either haven't been diagnosed, haven't been told that they have diabetes, and are probably unaware of things that they might be able to do to prevent diabetes or delay the onset of diabetes. Gestational diabetes is viewed by some as a pre-diabetes equivalent. We know that women who have had gestational diabetes are at much higher risk for development of type 2 diabetes, and this affects 2 to 10% of pregnancies. Now, there are some policy changes coming to the way that gestational diabetes is screened for and detected, and it will actually cast a wider net. So some estimates are saying that up to 18 or 20% of pregnancies may be affiliated with a diagnosis of gestational diabetes when the criteria for diagnosis are expanded. That's a really huge number of the population of pregnant women having diabetes during pregnancy. Now, gestational diabetes technically goes away after the birth of the baby. However, we know that somewhere between 5 to 10% of the women diagnosed with gestational diabetes, their diabetes never goes away, and they are actually found to have diabetes that is lasting. And sometimes this is type 1 diabetes or autoimmune-mediated diabetes diagnosed during pregnancy, but usually it's type 2 diabetes. And so even women whose diabetes goes away after the birth of the child, these women have a much higher risk for developing type 2 diabetes, and the risk is 35 to 60% chance of developing diabetes in the next 10 to 20 years. So these women have also been a group that has been targeted for enhanced screening, because we know that the risk for them to develop diabetes is high. Now, on the other end of the spectrum, adolescent prediabetes, and I start with adolescents because children before they are pubertal, it would be very, very rare for them to develop prediabetes to type 2 diabetes. School-age children primarily develop type 1 diabetes or autoimmune-mediated diabetes, and it is the prevalent cause of diabetes in pediatric age groups. However, during adolescence, during the pubertal growth spurt, insulin resistance occurs, and this is physiologic. So you need higher concentrations of insulin in order to have a normal pubertal growth spurt. And so this is the time when prediabetes may present, because if someone has a problem secreting enough insulin to overcome that physiologic insulin resistance, then their blood sugars will go up. And so adolescents develop prediabetes during this physiologic period. Overall, prediabetes prevalence is about 16% according to the NHANES data, that's nationally representative data, with 13% of that being impaired fasting glucose, and I'll give you the definitions of this in a later slide, but 13% have impaired fasting glucose, a blood sugar between 100 and 125, and just 3.4% have impaired glucose tolerance, so an elevated blood sugar after 2 hours during an oral glucose tolerance test. But when you look at obese adolescents, the prevalence of prediabetes is nearly double that. So it's about 1 in 3, or 30%, among obese adolescents, with 22.7% of that being due to impaired fasting glucose, and 9.5% being due to impaired glucose tolerance. And this just sort of graphically represents the way that I view diabetes as a spectrum. So you have a condition where you are developing diabetes over time. And the problem is that when you're on this end of the spectrum, this can go undiagnosed for a long period of time until you actually get to beta cell failure and diabetes, because this is relatively asymptomatic, and unless you screen for these conditions, you will not readily detect them. So we start with a normal glucose tolerance in someone who has a genetic predisposition to the development of type 2 diabetes because they have a family history, or they have a pancreatic beta cell defect that's either inherited or developed because of medicines that they're on. And then they could get a second hit, an environmental influence, such as an unhealthy environment, becoming overweight, becoming pubertal, becoming pregnant could be on this slide as well on this line, because so in combination with the genetic predisposition, the second hit of the environmental influence or the physiologic influence, depending on what stage of development you're in, will lead your blood sugars to increase. Now, your blood sugars are increasing because you're not making enough insulin to overcome insulin resistance, and you develop impaired glucose tolerance. This is due to a lack of first phase insulin. So the first thing to go is your glucose tolerance to a large glucose load. So this is diagnosed by oral glucose tolerance testing. And the next thing to go is your second phase insulin, and you develop impaired fasting glucose. So impaired fasting glucose may occur for different reasons than impaired glucose tolerance, and that's really complicated, and the mechanisms are still being worked out. But classically, these don't have to occur together. One can occur before the other, and they might be switched around. But you have to progress all the way to beta cell failure, meaning an absolute deficiency of insulin, before you'll have symptoms of polyuria, polydipsia, and other signs of diabetes. And then full-blown diabetes is developed. Now, this may be a point of no return where you can't return to relatively normal beta cell functioning. That's another reason why it's better to diagnose closer to the beginning, because we may be able to restore and return to relatively normal glycemia if treated before it gets to the point of no return. Shown on this slide are the criteria for diagnosis of prediabetes and diabetes, and they go by test. So in this column is normal glycemia levels, values that are generally considered to be normal, fasting blood sugar less than 100, oral glucose tolerance test 2-hour blood sugar on standard testing less than 140, and a hemoglobin A1C of less than 5.7%. These are widely considered to be normal blood sugar values. Then you get on the other side to diabetes, and we know that these are greater than or equal to 126 fasting, greater than or equal to 200 stimulated, and greater than or equal to 6.5 on a hemoglobin A1C. Anything in the middle meets the criteria for in the middle of the spectrum or pre-diabetes, an area where there may be an ability to return the person to normal glycemia with treatment. So I think that I've said a couple of times now why I feel we should be diagnosing the condition, but So the question is, why should we diagnose this? Why should we burden someone with a diagnosis of prediabetes before they actually have diabetes? And the reason became clear after the results of the diabetes prevention program came out. And that's really that now 3 large studies, one in China, one in Finland, and then the U.S. Diabetes Prevention Program have shown conclusively that diabetes can be delayed or prevented in adults who lose weight and increase their physical activity. This graph represents the results of the first 4 years of the diabetes prevention program. This was a study where there were more than 3,000 individuals who had to meet fasting and 2-hour blood sugar criteria for prediabetes to be entered into the trial. They were randomized to either placebo or usual care, metformin, or lifestyle with the goal of reducing their body weight by at least 7% and increasing their physical activity to 150 minutes per week. And this is the cumulative incidence of diabetes. So nobody had diabetes at the beginning of the study, but after 4 years, 20% in the lifestyle group had diabetes, close to 30% in the metformin group had diabetes, and between 35 and 40% of the placebo group had diabetes. So if you were in the lifestyle group, you reduced your chances of getting diabetes significantly, and there was a 58% difference between placebo and lifestyle. They stopped the trial, in fact, a little bit early because lifestyle was clearly beneficial for reducing the conversion of prediabetes to diabetes. Hence, the diabetes program has been translated into the U.S. The National Diabetes Prevention Program and offered mainly in the YMCA, but being translated more broadly throughout the United States. So this is a representation of what you would need to lose 5 to 10% of body weight. So we often quote, you need to lose about 7% of your body weight to realize a substantial reduction in your chance of developing type 2 diabetes if you have prediabetes. So if you weigh 150 pounds, this translates into a loss of 8 to 15 pounds, whereas if you weigh 300 pounds, it translates into a 15 to 30 pound weight loss, which actually when you ask people how much weight do you think you need to lose, they often, say 50 pounds, 80 pounds, 100 pounds. And when you show them, no, you actually probably just need to lose 10 or 15 pounds, that's much more realizable goal and much more attainable for most people. Okay, so if we're saying that we should diagnose the condition, the second question is, who should be screened? So if we should diagnose the condition and we know it occurs in 1 in 3 people, should we screen everybody, or what is the criteria for screening? And the published criteria is really to screen anyone with a hemoglobin A1C if they're age 45 or older and overweight. So overweight is the standard definitions in adults of a BMI of 25 kilograms per meter square or above. If a person is age 45 or older and not overweight but has metabolic risk factors, so for instance they have a history of gestational diabetes, they're not overweight but they're 50 now, and so you will want to screen that person because they have a substantial risk. If they have an extensive family history of type 2 diabetes, their parents had type 2 diabetes, then that's somebody else that probably deserves to be screened even if their BMI doesn't meet criteria. For patients under the age of 45 but overweight and an increased risk for diabetes based on other risk factors. So for adolescents, we screen when they're overweight and they have 2 or more risk factors that put them in the high-risk category. So the risk factors are coming on this slide. Risk factors are variable depending on the age of the person. So actually, some of the things that we think about in adolescents primarily are on the left side, if they are minority, race, or ethnicity, and have a family history of diabetes, we screen them for prediabetes during their adolescence because we know that this is a time of increased risk for them. People who carry their weight around their abdomen or have excessive visceral fat are an increased risk. And then, you know, sort of all of these symptoms that go along with the metabolic syndrome. Polycystic ovary syndrome is really a sort of metabolic syndrome equivalent, and these women deserve to be screened, or as I said earlier, history of gestational diabetes or having a very large baby. 10-pound babies tend to be born to women who had hyperglycemia during pregnancy. Okay, so what can we do when we detect that someone has a diagnosis of prediabetes? And I should go back and say that the standard way to screen for prediabetes in adults now has become A1C, with an A1C, hemoglobin A1C being between 5.7 and 6.4%, being showing an increased risk for the development of type 2 diabetes, and hemoglobin A1C greater than or equal to 6.5% being indicative of diabetes. And all of these should be repeated to verify the diagnosis. But if you have somebody with a new diagnosis of prediabetes, the first thing to do is to control the ABCs. So this is straightforward. A1C is equivalent to glucose control. If you have prediabetes, you're not going to be starting someone on insulin, but you may consider metformin, as was done in the diabetes prevention program, and you'll always initiate lifestyle change whenever possible. But because prediabetes is also associated with increased risk of cardiovascular disease and stroke, very close attention to blood pressure control, LDL cholesterol targets, and smoking cessation. Smoking cessation is very important. Those three things are very important to accompany any efforts to treat prediabetes. And then really the diabetes prevention program has really done substantial work to train a workforce who can implement the program cost effectively, to put the program in multiple places that are convenient for patients to have access to. The program has recognition and some quality assurance so that recognized programs will actually lead to financial reimbursement, meaning that insurance companies will recognize the benefits. The programs will measure outcomes and track what they're doing so that this program can grow and continue to be cost effective. So this also allows the U.S. Centers for Disease Control and Prevention to develop a program registry to sort of keep track of outcomes from different programs and follow these patients on a wider basis. So what we need now really are more intervention sites to deliver the program. A large percentage of people in the United States live within 3 miles of a YMCA, but that certainly isn't the case for everybody, and so there's an effort to develop intervention sites that will build infrastructure and provide the program outside of the YMCA and in communities at large. And here at Indiana, we're leading an effort to bring the diabetes prevention program to families, because we know that and children are at increased risk, their parents usually are at increased risk as well, and so we have a program called Encourage Healthy Families that utilizes aspects of the diabetes prevention program to trickle down to the children. And then health marketing will be important to support program uptake, to get physicians to refer their patients, to screen and refer, to increase referrals and use of the prevention program. So we're sort of at a state where we know the research shows that treating prediabetes is cost-effective and beneficial. And now the work primarily is translating that into the community such that the people that most need the program can take full advantage of the program. And so I left a slide of how do I get the materials, and the State Department of Health can help with this as well, but there are copyright-free, downloadable materials, and the websites are on the slide here. And that's it for my slide, so I'm going to segue to Julie.
Okay, thanks. So the good news is that we have really good information about strategies that can help to prevent or delay the development of type 2 diabetes. And as Dr. Hannon has previously discussed, the diabetes prevention program really had impressive results regarding the lifestyle intervention group. This group received intensive education on diet, physical activity, and behavior modification topics, such as problem solving, environmental cues, self-talk. The goal was for them to achieve a 7% weight loss within the first 6 months of the intervention and engage in 150 minutes of exercise per week. They reduced the risk of developing diabetes by 58%, and this was seen to be an even greater effect in individuals who were over the age of 60. They reduced their risk by 71%. So the authors concluded that really weight loss was the main predictor in the lifestyle intervention for decreasing diabetes risk. Much work has been done, as Dr. Hannon mentioned, to translate this information into community programs. The YMCA currently has 5 programs across the state of Indiana, and you can locate brochures regarding the program on the website listed below. Your patients can also access information to be registered for the program at that website. So the YMCA programs mirror the DPP study. They are a year in length. They consist of 16 core sessions and also have monthly maintenance sessions. Additional programs across the state can be found at the Indiana State Department of Health website. They list programs across the state for diabetes self-management education, and they are listed by county and also have contact information available. Patients can also go to eatright.org or diabeteseducator.org, put in their zip code, and be provided with a list of practitioners in their area if Y is not available close by. There's also our clinic. As Dr. Hannon mentioned, we work with youth ages 10 to 21 on diabetes prevention. The National Diabetes Education Program has great tools for supporting the messaging with your patients. Things about just the importance of diabetes prevention and also just how feasible it can be to make some lifestyle changes. My Game Plan is a brochure that has some diabetes assessment tools as well as some of the DPP tools like the calorie and fat calculator and some of their tracking tools. So if someone is maybe not able to get to a group session, they can start with My Game Plan. That's more of something someone can do on their own. So we have a lot of resources across the state with the Y diabetes prevention programs, and also with just different diabetes self-management education programs. But what about just practical tips when maybe you have 5 minutes with a patient who may or may not be at that stage of change where they are ready to make changes? So some evidence-based kind of messages around dietary lifestyle changes that can help to facilitate weight loss. So we know that the increase in consumption of sugar-sweetened beverages have paralleled the rise in obesity, and that sugar intake from sugar-sweetened beverages alone approaches about 15% of daily caloric intake in some population groups. And so for some individuals, simply looking at what they are drinking throughout the day could be enough to help facilitate 7% weight loss. For patients who really like concrete numbers, taking out a 20-ounce regular pop during the day mathematically results in a 25-pound weight loss over the course of a year. So just starting to look at what they're drinking. Also, we know that restaurant foods are higher in fat, calories, and sodium. A typical restaurant meal ranges from 1,000 to 1,500 calories on average. I selected these options just to kind of exemplify that information. I know with a lot of teens, macaroni and cheese and chicken tenders is a common choice, and even trying to go with maybe the healthier option of the turkey sandwich, you can see that the calorie level is still just higher than would be a meal at home. So starting to look at frequency of restaurant foods and trying to eat more food from home can make a big difference. There's also a lot of tools such as CalorieKing.com or the restaurant website where people can go to get a little bit more educated and make informed decisions about food choices when they're out. And of course, there is always portion control. So one way to visualize a well-balanced plate is to think about half of the plate having a lot of color with non-starchy vegetables, and then keeping some of those starchy foods such as rice, pastas, potatoes, corn peas to about a fist. If someone has a large fist, then maybe talking about it being a fourth of the plate. That ends up looking like about a cup of rice or pasta. And then also thinking about the protein being the size of the palm of your hand would be about a 3-ounce portion. One thing that we know is that when we are served more food, we all tend to eat more food. And so just even little tips like starting with a smaller plate and then looking at the balance of that plate can help to decrease energy intake. We also know that when we eat larger portions at a certain meal, we do not compensate it for eating less calories later in the day. So just starting to talk portions can be helpful. Writing it down really works. We've seen this at people who track what they are eating or also with physical activity see more results. And this was true in the DPP as well. People who wrote down their food intake saw greater weight loss. Increasing physical activity. There are exercise prescription and referral forms available. The Exercise is Medicine was an initiative done by American College of Sports Medicine and the American Medical Association. These forms can be found on exerciseismedicine.org. If you are looking for, a concrete way of writing down that advice to increase physical activity. I know at our clinic, when a patient is given the exercise prescription, they can take that to the local Y and have a 2-week free trial at the Y. So that might be something worth looking into in your area as well. And then, of course, just practical tips to get up and get moving, whether it's gardening and yard work, trying to schedule in 10-minute bouts of exercise. If patients don't have sidewalks around where they're at, trying to do, some extra steps as they're going about their errands. There are also walking DVDs that are available free of charge on YouTube, or if they do not have internet access, then checking with their local library. And a lot of these are done by American Heart Association. So I know when I talk with patients, they appreciate having some tools to leave with. And if your patients maybe do not have easy access to the internet, these might be sites to just check out and see if there are a handful of materials that would be most appropriate for your patient population. There is everything out there from different menus for a variety of calorie levels. There are recipes. ChooseMyPlate.gov has a series of 10 tips on a variety of topics. And I know something common that I talk about with patients, too, is how to eat healthy when you're on a limited income. And the USDA SNAP program has really great tools on how to stretch the food budget and how to include fruits and vegetables within a limited income. So those are some tools to check out. For those patients who do have internet access, there are many more websites out there that are great. These are websites that have some corresponding phone apps to them. This is just a handful that I have had good feedback with patients and tools that patients like to continue to use. So it's everything where they can route out a walking map and see how far it is, to MyFitnessPal, where it's a really comprehensive database. If you have someone who's doing some traveling for work and eats out a lot, it's a great database for getting information there. To Eating Well, where it will come up with a couple weeks or a month of a menu and select recipes, and you can have everything. It will even put it into a shopping list. So the good news is that we know modest weight loss works. Dr. Hannon already alluded to the fact that 7% for a lot of people is, when you talk with them, they a lot of times have a much bigger weight loss goal. And so I think that's just a very encouraging message to share with people, is that 7% weight loss has some great health benefit, and that 30 minutes of exercise most days of the week is important for the prevention of chronic disease. And, I hopefully this, has given, some tools that you can use with patients and in your clinic to help them have a starting point for making those lifestyle changes.
Thank you, Julie. Awesome tips for intervention. And thank you, Dr. Hannon, for showing us all the work we need to do on prediabetes out there. With 79 million people out there having prediabetes, we have nothing to lose and all to gain, no pun intended. Since this is a pre-recorded webinar today, and you may have come up with some further questions about detecting prediabetes with Dr. Hannon's presentation, or maybe additional intervention techniques, resources from Julie Pike, our dietitian today, I wanted to give you my information to be a focal contact person. I can take your questions and get them fielded to Dr. Hannon and Julie. and I'd be more than happy to facilitate all of that. My email, smurray, M-U-R-R-A-Y, at isdh.in.gov. It's on the screen. Or my local phone is 317-233-7299. Just want to put a last plea that the diabetes prevention program and the YMCA program, it's awesome that they took this initiative up to make a difference with the prediabetes patient. I would encourage, if you have a YMCA near your office or near your patients, have your patients contact their local YMCA for more information, and they can pretty much take it from there. If you don't have the luxury of having a YMCA near you, I would definitely encourage you to send your patients to your local diabetes centers where they can get additional help. So anyway, thank you so much, everybody, today. That's a wrap.